Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former Feeforservice doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct specialty care is the opportunity to make medicine yours, your style, your terms, your relationships. I am Dr. Bagares, and this is my direct specialty care story.
Dr. Fred Bagares is a board-certified physician in both sports medicine and rehabilitation medicine. His clinical interests include biomechanics, rehabilitation medicine, pain science, spine care, electrodiagnostic medicine, musculoskeletal ultrasound, and medical education. After medical school, he completed his residency in physical medicine and rehabilitation, or PM&R, at Northwestern University Rehabilitation Institute of Chicago, in addition to a fellowship in sports and spine medicine. Dr. Bagheres believes that movement is the key to living. He is fascinated by how diseases affect the way people move, which lead them to his care. Coming from an osteopathic medicine background, the transition to both PM&R and sports medicine was very natural. He has worked in a variety of settings, including a multi-specialty surgical private practice, academic medicine, military medicine, and also solo private practice. In his spare time, he enjoys spending time with his amazing wife, chasing his 2 children, and practicing jiu-jitsu. Welcome to the podcast, Dr. Bagheres.
Thank you for having me.
Fellow Filipino doctor in the house. Super
Absolutely.
stoked. One of the things that I wanted to open this podcast with is that we have not heard the story of a physiatrist before. So can you start us off with what is PM&R and what does it mean to be a physiatrist?
Absolutely. So PM&R is a fairly small specialty, but it is the medical specialty that manages conditions and disorders that affect the way people move. Typically as a result from chronic, congenital, orthopedic, or neurological diseases. So our bread and butter has been like stroke care, traumatic brain injury, multiple sclerosis, amputee care. But over time, it's evolved into these various subspecialties. So pain medicine, sports medicine, hospice palliative care, pediatric rehabilitation, neuromuscular medicine as well. So we're pretty much covering all over the place. But most physiatrists, if they're not in the inpatient setting doing acute care rehab, a lot of them are outpatient doing probably non-surgical orthopedic or pain medicine care. In terms of the main difference between orthopedic surgery, the big obvious thing is that we don't do surgery. A lot of our care is really focused on different types of injections. Some of us do EMGs. A lot of it is looking at the overall rehab picture. I think that's actually one of the big draws to PM&R. I actually went into medical school wanting to be an orthopedic surgeon, and after a while, I just kind of was like, you know what, I kind of like looking at everything, and that just kind of fits my personality. But that's pretty much the big thing is that I think overall orthopedic surgeons obviously do surgery. Physiatrists also tend to follow people further in their life, which I think was also really important for me.
Now, with understanding what PM&R is in relation to where it lives in the medical specialty world, how it's not orthopedics, I wanted to ask how your training was to be able to be a physiatrist in terms of when you were in training, what kind of autonomy did you experience, if any, and how did that manifest? Because with it being a smaller specialty, I find sometimes that when people are like, oh, you want to do rural medicine? Like, that was my experience, is like, create your own curriculum and we'll sign it off. So I'm just wondering about your training to be able to get you to this point where you're like, yeah, man, I'm going out on my own.
Right. My residency was amazing. I did my residency with Northwestern, formerly known as the Rehab Institute of Chicago. And we had a pretty broad at least back then, we had a pretty broad scope of exposure. As you like in terms of like the actual requirements, inpatient versus outpatient versus specialty rotations. I thought we did a really good job, or the program did a really good job of just laying it all out there. If anything, I think what I learned back then is that all residencies aren't the same. So I definitely ran across colleagues that had different experiences, but I ended up doing a fellowship after that. I had a lot of training. I felt really very comfortable as a general physiatrist. So I actually was planning on going into kind of an inpatient managing spinal cord and neurological disorders slash sports medicine, but there wasn't like a real job for that at the time. So I decided to go on to fellowship to do more in terms of learning sports medicine and musculoskeletal injuries and electrodiagnostic. But also more importantly, I really wanted to have interventional spine skills. But overall, I think PM&R, because it is so vast, I think you definitely have to have an idea of what you like and what you don't like just heading in, because I was kind of the guy that I wanted to do inpatient. At one point, I wanted to do a spinal cord injury fellowship. I thought about pediatric rehab. I mean, I was like kind of all over the place, which is, as a resident, was great. Like, I was just excited about everything. So I think as a if you're interested in physiatry or PM&R, you definitely have to be super proactive because, again, I'm 10 years out, so, or actually plus 10 plus years out. So I think the options are probably, it might be almost too many options at this point, but I think overall that's the way I kind of approached it. Is I just, every opportunity I saw, I just kind of went for it. But in terms of preparing me to make this jump, nothing. like I didn't know it back then, but that I was gonna be doing this now. But I'm sure we'll get into that too. So.
Well, that's great to hear, because that was my next question is, did you see any doctors who were doing cash pay physiatry while in residency or in medical school? And just because it is a very small subspecialty compared to family medicine, or the number of residencies out there is what I'm speaking to. But the answer is no, and that's not surprising.
Yeah.
I hope again that this changes in the future, given what you're sharing today. Now, let me ask you about your geographic location, because you are in Virginia Beach, Virginia. And I'm just wondering about what drew you specifically to that area. And do you find physiatry is something that is crazily needed in your area?
We were in Chicago at the time, and I didn't know where I wanted to go. And so I joined a practice out in Vancouver, Washington. Great practice, multi-specialty surgical group. But yeah, I'm an only child, and my wife is from Virginia Beach. I grew up in Northern Virginia, and all of the family was on the East Coast. So I knew we tried to get people to come out to where we were, but there's just too many. So we decided to move back eventually. But it was actually kind of hard to find a job in this area, because I remember distinctly when I was in fellowship looking for jobs in this locale, just not exactly knowing where I wanted to be, but I wanted to have options. And it was hard. It was hard to get callbacks. And I think at the time, the year prior to me graduating was a really big hire year. And so I think no one was hiring the next year. So when I saw the opportunity, well, we were actually on the West Coast, and my daughter was like 4 or 5 years old, and all of the cousins are right around the same age. So she started asking, when's the next time we're gonna see my cousins again? And up until when they're babies, like they don't remember, but now that they remember, I was like, oh man, how I think we got to move back. So like I remember I dropped her off at school, and I immediately started looking for jobs on the East Coast. And it just so happened that there was an academic position on the East Coast. I mean, I literally applied and just kind of went for it and got the job offer, and then we ended up back on the East Coast.
So let me ask you there, because Earlier, you talked about how your residency was amazing. You had so much exposure. You were like, what do I not do in my practice later on? And then you also talked about your thinking specifically inpatient. When your mindset shifted to, the primary thing is that I need to be close to family and I also need a job. How did your narrowing down of how you wanted to practice shift? Like, did you just say like I'll be fine with whatever is open as long as I can get a job because my family's going to be in Virginia Beach?
Right. I really, my priority at that time was to get my family as close as possible. So that was kind of like, once I knew that, that was not an issue. It was like, I just need to figure out a way to do it. And then in terms of like, is this a job that I could take, quote unquote? It really kind of came down to the finances. Like I remember like kind of crunching the numbers, and I was never really financially literate up until basically like right after fellowship, when I actually started, oh, I actually have to pay attention now. So when that kind of played a role into my negotiations, because I was like, I knew the number that I needed to safely go back and be able to pay off my school loans and so on and so forth. And so I guess it ever to each their own. Like just being home close to parents was really really important. So as long as I hit the number, like I was like, I'm good. Let's just go.
And I appreciate you answering that because many people in medicine, when they're with a particular amount of loans after, if they're not going to a loan repayment program because they're driven to move close to family or move close to like where they want to practice or whatever the reason is, and they're not getting like guaranteed loan repayment and you're having to repay with what you're making. I think that's a very excellent thing for people to hear in terms of your perspective on how you went through choosing your first job there. Because I will say,
Right.
knowing that there's other jobs that came after. So, in terms of this idea of taking an employment position that was like fitting certain needs, but then as long as it met a certain number, you were like, cool, I can pay off my loans as well as like put food on the table. You also then became a contractor with the Navy, as well as you then had another employment position with an MSO. Did you continue to take positions with those requirements in place, or did your requirements change as you went on to those other positions?
Overall, the requirement that really changed was honestly just a circumstance, and I'll explain. So the job I came back for was an academic position, which was great, but then it just didn't work out. That's just the bottom line, right? But I signed a non-compete. It is a two-year non-compete. And because I'm in Virginia Beach, there's not four directions to go. There's only three, right? So at that point, I was like, well, I can either move my whole family, or I could also start looking at the military as a way. And Virginia Beach or the Hampton Roads area is a big naval town. I don't know if you're military, but they have some military opportunities, and I just happened to apply for it. So that was definitely actually just great luck, because that's actually as I was exiting the second job and about to go into the contractor position. That's actually start when I started to think about like how else does this model work, and is this model for me? Like that's really kind of where things really kind of started for me. But then once I actually got into the position in the military, it was great. It was a sports medicine physician. It was interesting. If anyone's interested in these kind of positions, it was great in the sense that all my patients were like 20 years old, knee pain, shoulder pain. I had an ultrasound machine. The trick was that I worked 4 days a week, which was great, but I worked from 5 a.m. to 3 p.m. So in a sense, it was good because like I would be home for the kids and stuff like that. But I'm at work at 5 a.m., which meant I was leaving at like 4:15. But I really enjoyed it. So I don't think my focus had really changed. If anything, I got a little bit more focused, because during that time period, it was really kind of like I wasn't sure if I was going to stay as a contractor. Once I actually started to like, you know what, I really like this, versus should I branch back out? There's definitely pros and cons in the military system, like anything else. But I think it was actually a very important part of my story of how I ended up where I am now.
Hearing about your non-compete that you had with your former employer, Was there any issue with you practicing wherever you wanted to because you had a contractor agreement?
One of the stipulations was that like the non-compete didn't apply where it was working for the government. So that was real in this area. That's the role, the way out. And it's funny slash sad, I guess, because like I would run into people at the military facilities of other docs that were practicing out, and I'm like, oh, it's just almost like, I don't want to say it's like jail, but it's kind of like, oh, how long are you in for? Because we all sign non-competes. But so it was really like my only out. The only other option would be to write it out or move out of the area. So
I know that there are listeners out there who are nodding their heads.
yeah,
One thing to think about is especially if you're new to the podcast content, there are doctors in all sorts of states who've talked about non-competes and how to handle them. There's also states like California where non-competes are unenforceable. I hope that becomes nationwide, because it's ridiculous that because someone says you can't practice here, there goes your doctor. Like, there goes the expertise out of the area. So definitely something to consider, especially if you're earlier on in your journey. If you're looking to work with an employer, take that clause out if you're able to, or make the decision based on whether someone can take the non-compete out or not.
right.
So let me ask you there, because you were hearing again this like, oh my gosh, there's so many things I can do in physiatry, and then going to an academic position. You had another position. You went to be a contractor. Did you find it all like towards the tail end of your contracting journey that you're like, but I want to do more? Like, did the avatar patient that you just described, was that not enough for you? Did that have any
Right.
play in why you moved on from being a contractor?
Definitely. So while it was great, I was doing a lot of musculoskeletal stuff. I wasn't doing any injections for the spine anymore, and I wasn't doing EMGs. And I had actually tried to make it work out in the military, because in the military, they're like, you can do it, absolutely, go for it. But logistically, like it would be too, I would be not completing my primary job in order to fill these other holes. So at that point, I had stopped doing spine injections and EMGs for almost 2.5 years. And being as young as I was like, I didn't want to lose those skills, aside from just I like them. So that's when I tried to make it work, but it again, it wasn't going to work. So that's when I was like, you know what, maybe I need to go branch back out and try and do this again. But I'll mention it was also during this time that I started looking at telemedicine. So one of the I guess the my non-compete never mentioned anything about telemedicine. So, and this was like pre-COVID. So I was like, that's actually how I started learning about DPC, was like, can I do this? But I think it's telemedicine back then was like people were doing it, but I don't think it was like their primary mode of practice, at least not to my knowledge. So I went on the Facebook groups, and I look back at my old posts from back then. So it's kind of funny me asking all these questions like, does the non-compete apply if you're online? And so I met with lawyers, I did all this, and it all came down to, I don't know, it's a good question. And it's just very, very gray. Like, so I started to kind of approach that, but as an orthopedist, someone who does sports medicine, it was like even more like, how does that even work? Right. So what I ended up doing was my plan was to start off as a telemedicine practice, just to kind of dip my toe in the water and see how it would build. And it was a cash-based model. So at that time, insurance wasn't paying for telemedicine visits. So working, from 5 a.m. to 3 p.m., it gave me some time to to try and figure out this model and do all the homework. So I was hoping that, okay, I got plan A is I just stay with the military. Plan B is that I build up this telemedicine practice, and if I decide to go out, then I could use that telemedicine business to funnel a brick and mortar practice. So I I created a model. I had the EMR. I had everything set up. I had some patients coming through, and then I had a couple of people. I was just pitching the idea just to say, hey, what do you think about this idea? And so many people just said, wow, this is a really bad idea. Like, to put it lightly, like, that makes no sense. Like, how can you treat people without actually seeing them? And I understand their point, but at the same time, like I was like, I'm trying to be innovative. So I was just about to make the jump, and then COVID happened, right? And so in my, so many people call me. They're like, "Oh my God, you did it, right? You hit the jackpot!" Like, and I just laughed. I just kind of was like, "Wow!" As like in one move, it completely tanked my model because the two things that ever had to happen, number one, is that insurance would now start to take or pay for telemedicine visits, and number two, there would be no access to in-person visits. The two things that had to happen happened. And I was like, oh my gosh. So then I got a flood of calls. People like, hey, do you wanting to see me telemedicine wise? And they're like, the first question is, do I take insurance? And so now they're like, why don't you take insurance? So I was just like, oh God. And so everyone was like, well, maybe you can start to recredential, because at the time when I was in the military, all my contracts had lapsed. So I was like, maybe I could recredential. And again, COVID, like people were not working. So the processing time was forever. And I was just like, I'm done. I'm done. Like I can't, it's over. I just laughed it off. But it actually gave me the opportunity to build an LLC. So it was a good opportunity from a business owner standpoint. So
Let me ask you there, just stepping back into the telemedicine experience that you crafted. You're talking about how you had the EMR, you had everything crafted, people were coming in. I want to ask about what types of patients were coming to the
right,
practice and what were you doing to prove all those naysayers wrong with what you had built?
right. So a lot of them were people that I think actually the patients were looking for something different. That was number one. A lot of the people that I saw were actually already doing all the conservative management stuff, meaning like I would get referrals from people who just completed physical therapy or had done everything. And a lot of a lot of the people also just wanted someone to put the pieces together. I think that that's actually my main strength, is that as you someone goes to with an orthopedic or neurological problem, they'll get an MRI, they'll get an orthopedic surgeon consult, they'll get a neurosurgeon's consult, they'll get a million injections, and at the end of the day, there's no one to really put the pieces back together. So a lot of my patients at that time were kind of that mindset. Like I wasn't seeing like an ankle sprain. I was seeing people that had like, I've had back and leg pain for this long. I've seen this many people. What do you think? So it was more of like a consult, people wanting a second opinion more than people wanting like acute care. Like obviously I wasn't treating fractures and things like that, but that's when I really started to realize that patients were really not really happy with what was available. And they really just wanted someone to put things back together in terms of like, I mean, I would literally have patients come to me and say, like, I've had all these things done and I don't know what happened. Like, and I just need you to just explain what this all means. And with telemedicine in my model, I was like, I had all the time to do it. And I really enjoyed that piece of it. So I think that's kind of like what really drove that piece.
When you had this telemedicine practice set up, did you offer one-off consults as well as memberships, or did you have mostly one-off cash pay consults?
It was mainly just one-off type visits. And I'm still, even back then, it's interesting because like I was playing around with the membership model back then, because at the time there was no PM&R model. Number two, all of the direct care models were DPCs, which is a large majority of membership basis. Like, how do I do this as a membership? And again, as someone dealing with like an acute meniscus tear, I'm not going to see them forever, so it's like it doesn't make sense to see them chronically, or and charge them a monthly fee. So it's like, how is that going to work? But then there are some people that have, chronic osteoarthritis, rheumatoid, they have chronic issues. I was like, maybe it's that population. So then I was like, but I'm a sports medicine doc, and it's like, who should I be marketing to? So it turns out that I'm still right now doing kind of a one-off visit, kind of still kind of a fee-for-service type of model. But I'm still playing around with it at the same time. I'm trying to see what the market actually kind of wants, but I'm open to it. I guess maybe I'll share this one thing. One way that I have seen that I kind of played around with is if you're going to have a membership model aside from just the having the access, as a specialist, you have to be able to offer something. I think a lot of people in my space are doing, regenerative medicine, wellness. They're offering something extra. And while I do injections and I do procedures, it's really it's kind of against my general style. I don't like to do injections over and over and over. That's not how I believe people get better. So I was like, well, in this model, I have to give injections because I have to give them something. And so I was like, well, maybe I could get into like the wellness space or the functional medicine space. But I was like, I'm I'm kind of forcing it in a way of trying to like, what else can I add to make it worthwhile? And I'm not really quite yet sure what direction I'm going to go. I'm pretty happy right now with the way that it is going in terms of just like a straight fee for service, but I'm open to it. I'm still, again, this is now that I have time, I'm playing around with all these different ways of how to deliver care.
Amazing. And as it should be, right? Because you're thinking about how can I deliver care to my patients, not
Right.
what is the next code that will be covering my services.
Yes,
So love
absolutely.
it. Love it.
Absolutely.
Now, one more question on the telemedicine portion, because when you talk about having the time, even when you were in your contracting position to like find information on your patients to give them an amazing consult, that's a big challenge in DPC, direct specialty care, when you're independent
Right.
and the local hospital EMR medical records department won't play friendly with you. Do you have any tips and tricks on getting information so that you can have a very deep dive into a person's physical health before they come and see you?
Right. At least in my area, I really went into the Epic Care link. I try to get community access as much as possible because, as we all know, like notes and imaging studies, they somehow find their way into other charts. So I got access to all the local imaging centers as well. And Virginia Beach is a big city, but it's small enough that there's only really like 3 or 4 places to check. So like I have access to the local hospitals, but then also some of the local universities, UVA, VCU, ECU, Duke University, even Mayo. I have access there. And for the most part, that's really where I get a lot of my information. Now, in terms of like talking with actual practices, it is very, very difficult, I'm sure, as you can imagine. And right now well, I am and will be a micro practice, and my wife is the one that's helping with all the back end stuff, and she's not from the healthcare background. So it's very interesting. She's more from the business world, and she's just like, this all doesn't make any sense. Like I just had a patient that I referred to a specialist, and the fax machine, you know, we faxed a request, and did they get it? Did the fax machine have paper? It's that whole thing. So I guess the last thing I can say is that I think you really just have to have a dedicated person, diligent. And fortunately for my model, it's a relatively small practice, which is the way that I want it. That I think that following up on that stuff isn't too onerous.
I'm sure there's people just like shaking their heads at what you're
Yeah.
saying.
Hmm.
I know that I have this conversation frequently about how patients, when they go to a fee-for-service clinic, they're like, I can't access my chart. It's so not helpful. And I'm like, and then I absolutely get the whole like, well, we never got the imaging that you sent
Yeah.
over that you claim you faxed over. And then so now we save our documents and our faxes that we send to the patient's chart where they can literally pull it up and print it out. So we've had less barriers to also get our patients their studies that they need for their specialty visits because they can pull them up on their phones. And I love the descriptions of like, yeah, the doctor was, like, trying to skirt past it, and I was like, "Do you mean this calcium score right
Right.
here on
Right.
my phone that
Right.
you can see?" I love it. I'm like,
Right.
"Yes, go patients. Yay."
Right.
So,
Yeah.
yeah, love it. Now, tell me about your transition from your opening your own LLC, having a having a telemedicine practice, and then going into an MSO after that. So, what was I know you mentioned COVID. Was that the main driver to that led to the MSO?
Yes and no. I mean, if anything, there was some safety in staying in the military because it was a contract. So it's like guaranteed pay and so on and so forth. But I just knew that I was like, well, I haven't really established myself in this area, meaning like I got into this area in 2016. I practiced for 2 years at an academic center and then disappeared for another 2 years. So it's like people just talking with people like, where do you work? And if you're in the military, you can't be really seen by anybody. Like, oh, you're a doctor. Can I see you? I'm like, well, no. Are you active duty? Like, no. I'm like, okay. So it was always this awkward conversation. So, but I really wanted to kind of see medicine the way that I wanted it to be done. And even when in my very first job, I was like, I always had these ideas of how rehab and it should work. So it's like, okay, this is an opportunity where I can actually do something in person with it's basically I can control everything. And I just wanted to see how it would go. And it was from a practice standpoint, I was full. I had all the types of patients that I wanted to see, but at the same time, like an insurance-based model, like I found myself just not being able to spend enough time with the patients. And I fortunately never let myself head into like that 30 to 40 patient range, but even still, I was still seeing people like 20 to 25, which is still a lot. And I just started to notice that I was like, you know what, you're just not. I just wasn't happy. I mean, just flat out, like at the end of the day. And I think I was actually burning out, and I didn't realize it. Or I was burning out and I didn't realize it. And so the thing that really kind of like triggered me was that like there was just like the billing, like I was doing all this hard work and the money wasn't coming back, and just the philosophy of like, well, we'll just write it off and we'll go for the next one. It just didn't make sense to me. And I was like, this, why am I working so hard to maybe get money? Or the fact that like the billing claims were being managed by people who were not motivated, there was no incentive for them. So it really kind of like got me thinking like, is this what it is? This is what my life is. And I had this like long time ago, I set this timer on my phone of when am I going to like retire? Again, I'm not super financially literate, but at the same time, I was also thinking of that like the fire movement, like retiring early, things like that. So I'd set a date for my son's 18th when he graduates high school, basically. And I was like, that's the date that I'm gonna cut back. It's a financial goal, it's a life goal, so on and so forth. But then I found myself looking at that clock more like every day. I remember looking at at that timer and then going to work. And then I was like, man, this is not good. And I brought up concerns, and I just knew that it wasn't going to work anymore. And I I essentially kind of I'll call it, I just kind of quit. I just quit at the end of the day. I remember I was on a cruise with my family. I was on vacation, and I was like looking through my phone. So just kind of looking over at the sea and just like at the ocean, just looking at my phone and the pictures over the years. And I just noticed that my face, like I stopped smiling. Like I just saw myself change. And then like my daughter, actually, she's probably at the time she was like maybe 11 or 12. She said, or she was 12, and she was just like asking me, "Are you okay?" Like everyone's always like, "What's wrong?" I'm like, "Nothing's wrong." But apparently, like everybody else could see it except for me. And then I was literally on the boat looking over, and I just was like, "I'm done. I can't do this." Because I was like, it's either I quit medicine or I find a different job to do something, because it's like I'm just not doing what I want to do anymore.
Like you talk about your non-compete, it's like that's an even worse non-compete equivalent. It's like there you only have two options.
Right.
So in leaving medicine sucks for all of us who have gone to
Right.
medical school and have invested mostly our 20s in, sorry, we can't go to your wedding. Sorry, we can't go to your
Right.
Christmas party. I need to study for my board exams. So I'm so glad you did not quit
Right.
medicine because you already had your LLC, because you had already dipped your toes into a cash-based practice. What was the transition period like between opening up your practice as it stands now and your former job?
So 2 months. So I literally, as soon as I came back from vacation, I just said, I'm done. Here's my 2 months. This is the date. So my last official day was October 31st of 2023, and I opened up November 1st. But I think I was just mentally ready. I actually have this kind of idea journal. And I started going from when I created the telemedicine business, and I date everything and I write everything. Every crazy idea that I have, I write it down. And I went back to 2016. And so I had actually had these ideas for a long time. And I kept rewriting the same idea over and over and over, 2017, 2018. I just never looked at it in totality, right? And so I was like, bro, you've been wanting to do this for a long time. So I was just like, so once I saw that, I was like, I'm ready. I know I'm ready. So I just need to find a place and this and that. Like, I had already thought about everything else. I mean, there, of course, there's like EMR and things like that I had to work out, but just logistically, I was like, I think two months is a really short time for someone that's never thought about it. But at the same time, like, I had thought about it for such a long time that it wasn't that scary for me. But I know for a lot of the listeners, that still sounds kind of crazy. Even if you gave yourself a mental deadline of like, I'm gonna do it in 5 years, I think that it's kind of a hard pill to swallow. But I tell you, the one thing, and maybe for the listeners, the one thing that really kind of made it happen is like I had to find ways to make it real for myself. And the one thing that I did was I bought a website with my name on it. And that's when I was like, all right, man, you're gonna do it. I was like, you bought it, so like we got to do it. Plus, I had put in my notice, so I was like, well, like you gotta get back to work. So, but 2 months, short answer, 2 months.
Super powerful. And that's definitely something that physicians have used in different specialties in terms of the transition to another practice of their own, whether there's a non-compete or not, having a blog that is your own and that transitions later on to your website. Dr. Emily Scott is a great example of that. You have Dr. Fred Bagares. Dr. Haley Miller had her website just featuring her as a doctor. So she was an individual, not part of the system anymore before opening Montana State Diabetes. So I absolutely love this. And I think it's a great gem for people to take to think about when you're not yet ready, but you're like, I'm ready, but I'm just not ready to pull that trigger yet.
Mhm.
You can absolutely do things like this that empower you. And like you said, like you're motivating yourself to make this thing real because this is not a magical unicorn type of practice. This is legit. Like you're a physiatrist doing this. So love that. Now, let me ask you because you had done, again, this like dipping your toes into cash-based practice. And then you're like, this is like for sure, this is what I'm doing. In the state of Virginia, there's quite a few DPC doctors and specialty doctors as well. How did you ask, like, what was your mindset in terms of how you asked questions about what they were doing and how you would incorporate in their how would you incorporate what they're doing strategically into your practice or not based on you not only having these journal entries from 2016 just like thinking about this over and over but actively like shifting your mindset to no, I'm doing things to make this real.
That's a good question. I mean, I think overall, like I talked with a couple of the direct primary care docs in the area, and just trying to figure out like what do their patients, what do their practice needs, and like is there a space that I can fill for them in particular? And I I don't know if I really got the answer that I was hoping for, in the sense of like, oh, this is what I can do. Because especially as a specialist, I think one of the main challenges is that most people will look at me and say like, well, I need an injection for my knee. Like I can go and get that from my, insurance, my in-network physician. And I had to really change my mind in terms of saying like, you know what, they're trying to equate me to that, and I was like, I'm not that, right? So then I started to have to question of like, okay, what are you, right? Like what is your practice? Like who are you? What can you offer? And so to answer your question, I think the mindset is really, I mean, I hate it not to get too philosophical. You really have to understand like who you are and what you stand for and what it is that you want to do. And I think I'm a huge fan of DPC docs, and I've always like kind of wanted to talk to them about what was their motivation. And even though the motivation is the same, I was like, I still don't really know what it is that makes me different or makes me special. I mean, at the end of the day, I think that it's me. I'm the product. Yeah, sure, I give injections, and sure, I figure things out, but I'm the product. And I think trying to change the mindset of how to for you to appreciate how valuable you are to the community and what you can offer patients. Like I couldn't have read that in a book. I might have heard that someone say something that might have resonated with me, but I mean, there's been so many times over the past 4 months that I've been open that I'm like, rough days, man. I was like, why are you doing this? And I've had offers to do other things, to come back and to do this and do that. And but I'm just like, I think I just had to just really value yourself. As a physician, as a person in general, it's like, I think it's just something that we don't ever really have to stop and do. And I think when you're trying to market yourself and sell your practice, that's 100% what you have to do. Is like, you have to value yourself, because you'll get lowballed, you'll get this and you'll get that. And I'm just like, nope, sorry, that's not a good fit. And I just kind of move on. So I think really just valuing myself, is, to answer your question, was the mindset shift.
So pause, rewind that about 15 seconds and replay that over and over and over
Right.
again. Because
Absolutely.
absolutely, I mean, it is a vital part of what we are doing in direct primary care, and how we preserve our autonomy, and how we write our copy on our website, and how we speak to people about what we're doing. When you know that you are valuable, even though the former employer said, we're going to a non-physician model, or I'm so sorry, like you're going to have to see 80 million patients per hour so that you can make the same codes because we're paying you less per code. Whatever it is that makes one feel devalued as a physician in the regular fee-for-service system, stop, rewind now 20 seconds and listen to Dr. Bagheres again, because that is so imperative for what we are doing and to be able to
Absolutely.
thrive in this movement. So
Absolutely.
love it. So
Absolutely.
let me ask you then, because you were saying like, done, I'm doing it. I am actively doing it. I have my brick and mortar. I want to ask about the challenges and opportunities being a physiatrist with a space, because I hear people, and I know you have as well, of like, oh, I can't afford an ultrasound to start off with, or like, and you talked about the marketing piece and like who was joining your telemedicine practice, but in terms of as you continued on and had the space to then build out to make it fit what you wanted to bring to your community, how did that manifest in challenges and opportunities, specifically with physiatry care and orthopedic health services?
Right. So, fortunately for me, I had three main pieces of equipment that I use. So an EMG machine, an ultrasound machine, and a fluoroscope. And the fluoroscope I'd never owned, but I did own the EMG and the ultrasound. So as I was exiting, I just had to obviously I had to pay off the difference, and then because it was purchased through my previous employer, and I just purchased it from them. So I just knew I had to have that. But then it came up to like, well, to do injections of the spine, do I want to buy a new machine? And aside from the cost, the build out, these things can be like between 80 to $100,000. And I was like, I'm going to need an extra room to do that as well. And then I'm going to need extra staff, and it just gets bigger and bigger and bigger. So right now I did find a place. I'm renting space out of an internal medicine doctor's office. I have one room with both machines, but I'm not doing injections for the spine anymore right now. So I was previously doing it at a surgery center, and that's still a potential option, kind of given the right payer. Like while I don't participate with commercial insurances and I opted out of Medicare, I still see workers' comp patients. So that might be an avenue, but at the same time, like I think I really just kind of came down to what I feel my role is to help people put pieces together. Like the injections were great, but I realized that it's not the biggest thing in my opinion. Like it's really interpreting the injection, being there for patients, making them feel, that they have some control over what has actually happened. So in terms of like the challenges, I have all the stuff. I have a room, I have all the equipment. Nothing's really been challenging from that standpoint. Fortunately, the equipment that I did purchase wasn't super expensive, but again, I had already kind of planned for it. So if anything, I just made sure that when I paid off, I could use a credit card to get points because I love points. Points drive my travel. So that was kind of how I just figured out that piece. And then I just kind of paid it off like just like a here and there. But I'm not really looking to expand just yet, or if ever, because it's just a room. Most of my visits like yours are like 60 to 90 minutes. I was like, well, I don't need two or three rooms anymore to go run from room to room. But Yeah, I think that's pretty much it. So,
Fantastic. And let me ask you about the using the space in the internal medicine physician's office. Was that like, hey, I'm asking around for people or asking around if people have space? Was that like a Facebook marketplace listing like Jenna Silikowski and her buying her DPC off Facebook? How did that
right.
manifest?
So the person I'm renting space from was actually my physician, was my own personal like internal medicine doc, and they are a solo practice, but they're also still in the commercial space too. So I was just like, hey, if you hear, I just asked everybody, if you get, do you have any space, basically everyone that I knew. And so I just said, hey, do you have a spot? And he was like, sure. And this place is also right down the street from my house. So yeah, that's pretty much how I did it. It was like I didn't really look like online or anything like that. I just kind of called everyone that I knew and just said, "Do you have space?" And everyone has like one, and like I needed one room, so it wasn't too big of an ask. So
That's great. And in terms of the agreement, are you like, was that an easy negotiation? Do you have a particular year lease or are you just paying by the hour?
right,
How's that agreement working?
right. Right now I'm going month to month. So it's working out so far. The doc that I'm renting it from was more than happy because he wasn't even using the room. So I'm hoping it, so far so good. It seems to be working out. Like I don't really think I'm not in a rush to move at this point. So
And this question is coming from like I'm just assuming that there's a shared entrance space for patients of the practice, your practice as well as this internal medicine physicians.
mhm.
Yeah.
Yeah.
Go
Mhm.
ahead.
Yeah, no, it's the space actually works out because it is a medical building. So on the same floor is a physical therapy clinic and an orthopedic surgeon and primary care as well. But so it's, from traffic wise, it's good. People picking up stuff and seeing my practice, my signs and everything like that. It seems to be working out.
I'm laughing because I assume that this has happened and I hope it has. But the person who's sitting there, patients in my old practice, like an hour and a half, and they're like, how come Dr. Bagheres' patients keep moving and moving
Right.
and moving? And
Yeah,
I'm
yeah,
still
yeah.
sitting here parked in the parking lot waiting room. So I that's why I'm laughing. But oh my goodness, that's amazing though that you do get that. Hey, what else is in this amazing medical building? Awesome.
Yeah.
Let me ask you now about your journey in opting out of Medicare, because that
Sure.
is a big challenge, especially for specialists like Dr. Grace Torres, another fellow Filipino doctor. But she talked about how in podiatry, most of her patients were going to be with a Medicare plan. And she was like, when I let them go, I made space for people who valued me and who wanted to pay cash for my services. So, what was your journey like opting out of Medicare? And did you ever have any hesitation to opt out or not?
So I did opt out of Medicare. I started that process about, like, it's interesting because like I wasn't sure how it would happen, because when I quit, or I put in my notice about 2 months prior to me actually leaving, and I was like, maybe I should start opting out now, but I didn't want to like throw up flags at the same time. So and cause problems like towards the end. So I actually chose about 2 weeks prior to me leaving. And it was fairly simple. It was kind of anticlimactic because it's literally just a form. And I was expecting something, I don't know, something bigger. And but then I was like, well, when does this actually get approved? And so it took about 2 months, I think. No, maybe about 6 to 7 weeks before I actually um, figured it out. And I never got a letter. I never got anything like that. I just went to the website, and using the opt out tool to figure it out. But in terms of the decision, it was easy. I was like, I got to burn the boats, and I was like, I just can't do it because it's just too easy to get sucked back in. I mean, even now, like I do run into some problems a little bit because I'm trying to figure out in terms of like partnering with other practices and offering my services as a 1099. And still the same issue is that even though I'm 1099, I still have to be somehow credentialed through them. And I was like, see, I'm glad I didn't do it because it's just gonna, I mean, obviously you need to see people, you need to make money, but I was like, I'm not gonna get sucked back in. I just told myself that. I was like, no, I'm done. So mentally it was very easy for me. I didn't I see all the posts I won't be able to do locums work. I think that was a big concern of mine, but I'm done. Like I just was like, I don't care. My two happiest jobs prior to being a physician was selling shoes at Foot Locker and working at the airport, escorting people from by wheelchair. And I was like, I would much rather do that. I was so much happier back then. So I just kind of was like, I'm done. I'm done. So
I love it. And I'm sure that if people stop and think that they would find other jobs, like I used to teach summer camp at the Sacramento Zoo, and
right,
I'm like, that versus asking someone if they wear their seatbelt during a Medicare physical wellness
right,
visit,
right,
no, thank you. I would
right,
absolutely take scissors and glue sticks in my pockets any day. So love
right.
that. Now
Absolutely.
let me ask you this because this is something that I was like, oh my gosh, when we set up your interview, I had just doing research for this interview, I was like, how is that your former employer has an announcement about you leaving the practice on their page? Like that was something that threw me for a
Right.
loop. So can you tell the
Yeah,
audience about what happened, what transpired there, and has it affected your practice in a good or bad way at all?
sure. So, yeah, I mean, the big thing I noticed, quickly right after is that the internet, Google searching your name is huge. And so I wrote a letter to just my departure letter to patients and prior to me leaving, and it went out by paper, right? That's just kind of just from that standpoint. And then I noticed like 6 weeks later that after I had left the practice that they now posted it online. And I was like, why post that now? But what it did do is it actually bumped my ranking down. So it's now the first thing. And so I can only speculate. I'm not sure exactly why they did that then because I was really pushing for them to do it way before I actually left. And that was a struggle and a different conversation. But it didn't really affect me if at least that I can tell. But I there's not really much for me to say about it. I was just really kind of confused because I had already been gone for 6 weeks. So why post it now? But at the end of the day, press is press. My name still pops up and my other two websites still pop up. So it hasn't really bothered me.
Now, with your practice, MSK Direct, I'm super excited to start asking these questions about the details of your practice because there was a PM&R doctor that I had met who's based out of Vegas. I had met him at the Take Medicine Back conference early in February, and he was like, I could never do DPC. And I'm like, my hands are
Right.
doing the like, what is Mr. Burns like moving of the
Right.
fingers when
Right.
people say these things to me. But for you, when you opened up your website, you had your room, you're like, I don't have my fluoro today, might be coming down in the future. But did your services start off with like a set number of services and then have you expanded from there? Or have you listed everything you do to see what sticks?
Yeah, it's right now it's just a set number of services. And for the most part, I it's really the patients that have actually been seeing me really they're not really interested in the injections. It's really been more of like, I've had the injections. I just want to know what's wrong. So most of my care, like again, is really just trying to be a good doctor and trying to figure things out for people. But again, I think that people are kind of maybe selecting me for that reason. And I think my website kind of goes in, like you read my general approach, and even on my Instagram, I have a certain style of practice. And I mean, injections are great, procedures are great, but there's no shortage of people doing procedures, at least in my specialty. It's really there's really a place for people to help actually put things back together and explain exactly what happens. Because I think a lot of people perceive these procedures that we do as like the end all be all, but it's not. It's like, what does the procedure mean to you? What does it allow you to do? Does this injection allow you to sleep better, get off of medications? Are you going to move more? So I haven't really pushed doing more procedures because to me, procedures aren't what is missing from the community. It's people who actually understand rehab and how pain works and looking at the natural history of chronic musculoskeletal disorders. Like there's just, I mean, I'll say it right now. There's no one like me. I'm the best. There's just really, I'm just like I said, value yourself. Like I'm telling you right now, I'm the best. come see me in Virginia Beach if you want to get figured out. But so, like I said, the services isn't my sell. It's me.
And I think about how, at least we were taught at Creighton, 80% of what you need is coming from the history and not the 20% of physical exam. Absolutely, that's going to back up what your differential is when you're thinking. But this is why going to doctor school matters, because we've had the training in and hours, thousands of hours more than a non-physician provider to be able to think. And then that allows us to then, especially after you realize that you are valuable, be able to talk with your patients with the time you need to be able to share exactly what is going on in your head, how you came to a decision, and how to explain that in plain English rather than medicalese. So I absolutely love that that's what your value proposition is, that is the value proposition that you find your patients are loving. So let me ask you here about your website. When you have your services listed and there's a contact form, what does it look like after someone says like, oh, I'm totally interested in this practice, I want to learn more? Do you have meet and greet, phone meet and greet, virtual meet and greet? What happens after a person says, yes, I'm interested,
Right.
on your contact page?
I'll get an email and I just call them and see what it is that they need. I've had a lot of patients from my former practice try to follow up with me. Some continue to follow me. Some of them it wasn't a good fit. But I'm a big fan of calling because again, that's where I think I shine the most and where I can actually really answer questions and sell myself when necessary. So I'm also trying to eliminate the tech. I love tech. I know you love tech too, but I'm trying I shouldn't say eliminate the tech, but try to increase the human interaction. So I try to call the patients, text them as soon as possible. Like I had a patient the other night. They texted me like at 8 o'clock at night, and I just said, "Do you want to talk?" And she's like, "Sure." So I just kind of just handle it right then and there. I mean, that's just kind of what I know. That's not the way that everybody does it, but like I don't know, it motivates me. Like if like I if I was a patient and I just was like, "Oh wow, this guy actually." I mean, I hate to say it, this guy actually cares and wants to is really excited to talk to me. Like I want my patients to feel that way.
I love it. And I will quote Dr. Amber Beckenhauer, you do you. This is your
Right.
practice. You do you, man.
Yeah, yeah.
So let me ask you now about the website and the analytics. When you started, did you have the video that exists of you talking about the practice on the website, or was that something that you added on later?
That was kind of from the very beginning. And part of that also was I had the website up prior to me actually opening, but then I just kind of de-identified it. So like I took out my name. There was another timer. I guess apparently I'm a big fan of timers. There was like a countdown timer of this big reveal kind of a thing. But doing that video was like took me like a million takes. And it was like, again, I have a microphone here. I'm trying like, what am I trying to do? Am I trying to like be on camera? Like that sort of thing. But it was a great exercise because I was like I had to really concisely tell people what it is that I do without losing their attention, that sort of thing. But yeah, that's my main video. I have some other things I'm working on and I'm hoping to kind of build off of that kind of stuff. But yeah.
I love it. It's such a transition from what you shared early on before your direct specialty care journey in working on the business. That's not a thing
Yeah.
that we do when we're employed. So now let me ask you here about the places that people most visit on your website. Do you see that people are visiting a particular page more so than others? And have you adjusted your website to speak to that data?
It's the way I have my website set up. It's basically the landing page is the main page. So they don't really, I've at least analytics wise, they don't really click past that too much because everything is on there. And I like that by design. I hate clicking. I try to avoid clicking. I assume everyone doesn't like to click. So I haven't really noticed any people kind of venture off too far from the click. I've noticed a lot of people will just go off a straight Google, like you Google search and then like you get that box on the right. So I've definitely had a lot of people just go straight off of that to call. I never really understood what all those hyperlinks were, but now I do on the side. So getting your Google straight is super important for sure. I've always known it was important, but that's where people look, and that's just the way that the game's played. So that'd be the one advice I have is that if you can Get your Google business account, grab it for yourself. That took a while. That took a long time because I had all these great reviews with my old practice, and at the time I wasn't sure if they were going to release it back to me. So I opened up a separate Google, a separate Google business, and then it turned out they actually did release it. So now I had two, and then I had to consolidate into one. It was a whole ordeal, but it took a couple months to get that thing straightened out. So because I looked really messy online. Like it showed my old practice. It said I was permanently closed, and then I had all these other practices. So it was a mess. But yeah,
I totally echo that. And that's something that even if you are employed, you can still claim your
yep,
Google profile as like Dr. So and so.
mhm,
But yeah, I'm going to challenge people. Like, if you are posting this week, anybody on social media, tag my DPC story and put hashtag stupid postcard on your post because that postcard, it was like, that's what
yeah,
drove me nuts. I mean,
yeah,
I wish that I had done my Google page earlier
yeah,
because at least I live in rural America. So, like, I don't have a physical mailing address. You have
right,
to mail to PO boxes and they don't mail to PO boxes. So I was like, well, this is an amazing catch 22. So
yeah,
thankfully it worked out that I could send it to somebody who did give me the postcard from my address that I sent it to. But it was like, oh my gosh, so
yeah.
maddening. So yes, like I totally agree with you though.
Yeah, yeah. But I do think that did help a lot. So I think it's worth it. So if you can do it if you can claim your profile before you leave, that's great. That's probably your best case scenario. But it's just don't give up on it, especially if you have good reviews on there. So
How about, because when you spoke about your contracting with the Navy, keeping up your set of skills was important to you. So you've talked about like, could you provide services to other people? How are you focusing on making sure that your scope of practice is still where you want it to be going forward?
I think part of it is actually trying to, number one, I don't think I want to be a big practice ever again. So having a single room is very intentional. I think if I saw a second room, it would make me anxious that it's not filled. You know what I mean? So that's probably the main thing that I'm doing. I think number two is actually kind of narrowing my focus and narrowing down my skills. Like I like doing spine injections, but I don't think that it's necessarily something I have to pick up again. So kind of narrowing my focus, and I don't want to say give up, but I am kind of giving up one part of my practice in order to make this work. I think that's probably a big barrier for some people because I think if you're going to have an interventional pain practice, it's very overhead heavy. And I have met some people trying to do the same thing, and they had to kind of convert back into some sort of hybrid. So you have to kind of be okay with either managing the overhead or giving it up for a little while. I think the other thing that I'm doing is that I'm really trying to just keep my practice as small as possible. Like I feel the urge to get back on the wheel and just make money, make money, make money, see more people, so on and so forth. But I've really enjoyed, I think I could be stressing out about not being busy right now, and I am busy, but I think you almost have to really take the time when you're building up at what you're actually earn back. I've been in practice or in business now since for the past 4.5 months, and I've seen my kids go off to school and come home every day since then. I've even driven them. So I've probably spent the most time with my wife that I ever have, which is great too, like having lunch with them. So I think really starting to actually appreciate the non-business benefits is probably larger than the business itself. So I've kind of curated my life to kind of really just be about family, as you can see, like is just always important. It's very easy to get busy. I'd looked at some opportunities where I would be traveling and expanding my practice a little bit, and I automatically kind of have to draw myself back. I'm like, nope. I was like, that's not who you are. That's not why you're doing this. Of course, I like to help people, and of course, we all like to have really gainful employment and things like that. But I think you have to find something else that's not practice related to anchor you. I think that's at least for me, that's what really helped out.
And I think it really speaks to you valuing yourself. You're able to see that about yourself also. I think
Yeah.
that when you're so nose to the grindstone, it's really hard to see things like that, and what
Yeah.
is really driving your future. So that said, you've said before publicly that your job will never love you. And you talked
Mhm.
about the timers that you've had on your phone, whether it be your son turning 18 so you could retire from medicine or other timers. I want to ask specifically about your direct care practice now. One, do you have a timer? And what is that timer for if you have one? And do you find that that statement is still true, that your job will never love you because you're a direct care doctor?
That's a really good question. I still have one timer that's for my son when he graduates. I think that's just more for it actually more probably makes me more sad because it's just like them leaving the nest is getting closer and closer. But in terms of like, will my job ever love me back? It's not the job that loves me back. I think that the patients actually love me back more, or I shouldn't say love, but like I feel the patients more than I ever used to. Um, I used to be ashamed of, or shame, I am ashamed of it now, but like I would see people at the grocery store and I'd give them enough time and you're just like, oh, like I would kind of cower because I was like, I forgot their name or like, was I short with them that sort of thing. And I think being more connected to people was a big driver. So I think that's the way I guess it kind of loves me back is that I'm allowing people to connect with me. Maybe that's a better way to say it is that I feel probably more connected to people in general than I ever have before. And that was really that was one of my strengths prior to medical school was like my ability to connect with people. And so in terms of, is it ever going to love me back? I'm like, well, at least I'm now giving the job an opening to, to feel something. So I think I was just like everyone else. I was just so numb for such a long time that I just kind of forgot who I was. But yeah, I'll tell you this like real quick. This is on my mind. The year prior to me actually leaving, I was getting like these weird like chest pains, right? And like I'm kind of a grinder, like, and I'm like, oh, I'm fine. Work out, do this. I'm fine. And so then I was like, I keep getting it. And I was like, I'd be in the middle of clinic and I'd be like, I'll be right back. And then I would leave, I'd come back, drink some water, I'm fine. I was like, okay, it keeps happening. And then all of a sudden I saw my primary, saw a cardiologist, stress test, normal, normal, normal. Um, the day I decided to quit was the last time I ever had that chest pain. And to me, I was just like, wow. And even as I'm a very introspective person, and that to me was like very, very eye-opening. It never occurred to me that that's what that was. But I think overall, it's been a crazy, crazy journey. I mean, I really am really glad I woke up. I'm glad that my kids, honestly, they would ask me what's wrong, and I would I'm glad I listened to them. So I'm just very thankful.
Amazing. Well, we are all thankful for you sharing your journey today. Thank you so much, Dr. Bagares.
Absolutely. Thanks for having me on.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.